cardiovascular disease series. And this series and forum is going to comprise of therapeutic strategies confronting variation in acute myocardial infarction. And we have interesting talks and a great forum. Firstly, acute myocardial infarction is a life-threatening cardiovascular event resulting from acute occlusion of coronary arteries or arteries indicative of emergency management. Although mostly related to coronary plaque rupture with acute thrombosis, acute myocardial infarction varies a lot in manifestation, including AMI with non-obstructive, obstructive coronary artery, the MINOCA, Takotsubo syndrome or cardiomyopathy, AMI with cardiogenic shock, and AMI with multivessel disease. Different therapeutic strategies, different short-term and long-term outcomes are expected. Serious decision-making steps and pitfalls are to be presented in this webinar. So I am Bijoy Rajbanshi. I'm a cardiovascular surgeon. I work at the Nepal Medicity Hospital in Kathmandu, and I'm also the president of Cardiac Society of Nepal. My co-chair for this webinar is Dr. Yi-Chih Wang. He's a clinical associate professor at the Division of Cardiology and Department of Internal Medicine at National Taiwan University College of Medicine at National Taiwan University Hospital, Taipei, Taiwan. And there are a few disclaimers that we would like to mention. The content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of APSC. The view and opinions expressed in this webinar are those of the faculty members and do not necessarily represent those of APSC. And another housekeeping, the live streaming content of this webinar will be made available via APSC Cloud, APSC Facebook, and YouTube page. So let's get started with the webinar. And it gives me great pleasure to introduce to you all our first speaker, Dr. Supawat Ratanapo. He's from Thailand, and he's working at the Cardiovascular Disease Division at Department of Medicine in Phramong Phutklo Hospital and College of Medicine in Bangkok, Thailand. And he's going to be talking on myocardial infarction with non-obstructive coronary arteries, MINOCA emergency, intervention or medical. Dr. Ratanapo.
Thank you so much, Dr. Rajbanshi, for introduction. It's my honor to join APSC Cloud webinar today. And Thailand is still a morning time, but let me show my slide. So today I would like to talk about myocardial infarction with non-obstructive coronary arteries, or what we call MINOCA. Let's see that we need emergency intervention or just medical treatment. I don't have any disclosure regarding this topic. We should talk about the definition of MINOCA, how we diagnose the MINOCA, approach and current management per society statement, and we see what medical therapy or invasive treatment that we can offer to this group of patients. Let's first start with my case. It's a 60-year-old Thai female with history of AMI with a primary PCI2 proximal to mid-LVD 6 years ago, diabetes, hypertension, dyslipidemia, claustrophobia, and morbid obesity. The patient presented to my clinic with a progressive chest pain for 3 days. We check in the ECG, it looked like have a Q or infarction, and we check the troponin at 0 and 1 hour. It rising from 24.5 to 27.8 with not bad on renal function. We did a bedside echocardiogram and have an EF 40 to 45% with atrial hypokinesis and mild aneurysmal change that may correlate to the ECG. So we send the patient for the cath lab, and my colleague called back that the patient did not have many blockage. It's not that bad. So let's talk about MINOCA. And this case is fit to the criteria too. These are the patient medication, everything look all right. Okay. Okay. Next, we're gonna talk about Minoka. What is the definition? How we diagnose a Minoka? So the current statement, we start with the first mention about Minoka is from EAC working groups in 2015. Then later we have a HA statement in 2019, follow with a ESC guideline on NST Elevate ACS, also mentioned about Minoka. There's some change that I would like to mention about the definition of a Minoka in those guidelines. First of all, when we talk about Minoka, we talk about the patient have a MI, myocardial infarction. It defined as that you have a clinical of myocardial ischemia or injury, along with the rising and falling of cardiac troponin with supportive evidence such as abnormal echocardiogram, dynamic STT chain, or the symptom of chest pain. So Minoka is a subset of a myocardial infarction. Minoka, when we found that the patient have less than 50% stenosis of a major coronary artery, we define the patient as a Minoka. It can cause by coronary and non-coronary pathology condition. In terminology, initially we talk about ANOCA, INOCA, when we talk about non-obstructive coronary artery. However, we're gonna diagnose the patient as a Minoka once the patient have a positive cardiac enzyme more than 99% of percentile. So when we look where is a Minoka, we think the patient with a ischemic heart disease, the patient divide to chronic coronary syndrome and acute coronary syndrome. The Minoka is in the arm of acute coronary syndrome when you have elevated troponin and have a stenosis less than 50% on major coronary artery. When we look on the initial criteria in 2015, they need three things. First, the patient should have an AMI criteria, both positive cardiac biomarkers and some evidence that support that the patient have an AMI. Second, the patient have a non-obstructive coronary artery on angiography. It either not specify have to be invasive or non-invasive. And then the patient know any clinical of other cause of that can rising the troponin. But based on this guideline, there's one thing that is included as a Minoka. You can see in some original papers, they still count as a Minoka, such as myocarditis and Takotsubo cardiomyopathy. Then EHA come with a statement in 2019 together with the updated of a ESC non-state NST ACS guideline. They have a little bit change because the old guideline in 2015, they use a third universal consensus of myocardial infarction. But the new guideline use a fourth universal definition of myocardial infarction. So first of all, it's the same. You have a rising and falling of troponin plus evidence of myocardial ischemia or infarction, like EKG symptoms or abnormal echocardiogram. Second, you have non-obstructive coronary artery defined as like a cirrhosis in major vessels less than 50%. It can be in these three groups. First of all, almost normal coronary artery, just mild luminal irregularity, stenosis less than 30%, or the patient just moderate disease, 30 to 50%. The last thing that's a big difference. There's no specific alternative diagnosis of clinical presentation. They rule out peri-embolisms, sepsis, and also mention about myocarditis and Takotsubo cardiomyopathy not count as a Minoka anymore. Okay, so when we look through the fourth universal definition of MI, we're gonna look just only MI type 1 and type 2 in the patient with Minoka. So when we look through the Minoka with the new definition, they also have a specific cause, like it can be from the plaque rupture, erosion, thrombosis, spontaneous coronary artery dissection, some type 2 MI like a supply-demand mismatch, coronary spasms, or coronary microvascular dysfunction, the smaller blood vessel that we could not see by the eyes. They also mentioned about another cause of troponin elevation. In the initial guideline, they may count as the Minoka, but nowadays it's not Minoka anymore. as I told you, heart failure, Takotsubo cardiomyopathy, myocarditis, PE, sepsis, not Minoka. So we look through the preference of Minoka with a new criteria in a 27 largest clinical trial. We found that the preference average around 6% on the patient with acute myocardial infarction. When we look through the older data from the GUSTO 2B, when the patient present with an unstable angina, the patient tend to have more non-obstructive coronary artery. The patient who have positive cardiac troponin as a STEMI or NSTEMI have average degree of non-obstructive coronary around 5 to 7%. When we look for the prognosis of the patient with Minoka, we found that at 12 months, the patient have mortality around 3.4%. And when we look at the in-hospital mortality, is around close to 1%. When we compare the patient with a real STEMI with obstructive coronary artery, Minoka have a better prognosis. However, when we compare to the normal with our evidence of MI at all, Minoka also increase the risk of mortality and morbidity in the long term. Next, I would like to talk about management of Minoka. Should we do emergency intervention or just medical treatment? So first of all, before we approach, I talk about that we do angiogram, do all kind of stuff. There's some limitation of evidence-based. What should we do? When we divide how to approach, I divide into 4 steps. First, emergency supportive care. Second, working diagnosis of Minoka. Third, to give some cardioprotective therapy. And fourth, do a cost-targeted therapy for the patient with Minoka. The first one, emergency supportive care, treat all life-threatening arrhythmia or cardiac shock or unstable hemodynamics. Try to immediate the underlying mechanism that make the patient have Minoka. Revascularization, not always good therapeutic option in this case, and I can say in most cases of the patients. Then we go to Minoka workup diagnosis. You have needed 2 steps. First, we exclude disorder that mimicking acute myocardial infarction and cause of like a rising troponin, like a PE, myocarditis. Second, once we thought the patient have a less than 50% stenosis and fit to the criteria of Minoka per AHA recommendation, then we try to identify the cause that we can treat. This initial workup from the first statement in 2015, you can see that they put it broadly what you should do, both invasive and lab test. And the question that what should we do first? Then AHA come with what we call traffic light sequence of diagnosis of Minoka. They divide into 3 colors like a traffic light. So let's see what is in. First of all, they make sure that you have diagnosis of acute myocardial infarction with the criteria that have rise or fall of troponin, fit to the 4th universal MI definition, either Taiwan or Type 2. Second, one we know is a AMI, and we know that the patient have a less than 50% blockage. Then we work on the working diagnosis to rule out that is real Minoka. You have to make sure you don't overlook obstruction. Some obstruction, branch disease may cause a rising troponin, and then we did not see it, and we thought it's just a Minoka. Second, we work up on non-ischemic cause of myocardial injury. And last one, when we sure it's a Minoka, we find the specific cause inside the coronary artery that what can we treat for the patient. So on the traffic light again, I go back. They're going to put on the red one. You try to find out, as I told you. Second, you're working on the diagnosis by either cardiac imaging, angiography, intravascular imaging. And then you work up on the cause that mainly focus intravascular. And they also mentioned about the physiologic study. When you see the patient with a blockage in the 3rd group of the criteria, 30 to 50%, you might consider do the what we call FFR, physiologic test, to make sure there no ischemia. They found 1/4 of the patient, actually the blockage worse than we thought. But if the FFR normal, it means no ischemia or more than 0.8, we can diagnose the patient as a minoca. The APSC 2020 non-steroid ACS guideline come with the same things, with a traffic light in the different direction. And they change the definition as a ASA. The cardiac MRI intravascular imaging is a class 1 recommendation. And they also mention that how important of a cardiac MRI that we can use to screen the patient with minoca. Keep in mind, even we do a lot of our workup, 25% of the patient still we don't know the cause of minoca. So there's many trial and research try to find the roles of which assessment should we use. MRI become a critical that they can reclassify the patient up to 68% to myocarditis, tachycardia, or nothing. Heart minoca trials, they try to combine OCT intravascular imaging together with cardiac MRI in women, and we found that in minoca in women, when we use OCT together with cardiac MRI, we can find the cause up to 84.5%. These are some example what we find from the OCT intravascular imaging, like a plaque rupture, intraplaque cavities, increase the plaque from the last plaque, from thrombus, or like some spasms. These are examples from the MRI, what we found, and help us to rule out myocarditis, and also some infarction or even tachycardic cardiomyopathy. So from the all imaging, nowadays what we use, especially in the green light, first we recommend to use MRI, and after angiogram, we may recommend to use intravascular imaging. The first one is OCT, or if you cannot use OCT, you can use IVAS. Then we can find the cause of minoca inside the coronary artery. Then, if it's unclear, the blockage is bad or not bad, you may do some like a functional test or test for the some coronary microvascular, like a provocating test. If we think the patient have the thrombus from the outside, we may do a TEE or thrombophilia workup. This one is interesting because initially from the research, they say that we use only a coronary angiogram, do catheterization to make sure it's more than or less than 50% stenosis. However, now we use a lot of CT scan that have more benefit. We found that the CT scan, coronary CT in the right patients, we can have high negative predictive value up to 90.9% to rule out obstructive coronary artery. So when we first screen in the red light, whether it's blocked or not blocked, now you have two options. Send the patient for coronary CT if you not suspect the patient have a real obstructive coronary artery, or send the patient to a routine standard angiogram. After we find out the cause, then we do cardioprotective therapy. However, the most of medication that we use nowadays is based on obstructive coronary artery. We're not sure how much impact of the medication. From the Sweetheart Registry, they follow the patient with minoca. Most patients is 65 and 61% of women. Women have minoca more than men, and found that the statin ACE inhibitors may have benefit for the patients. But you have to think that on the minoca, there's a minoca who don't have any blockage at all. This group may not have benefit from any of medication, and also minoca who have 30 to 50% stenosis. This group of patients may benefit from statin. So they also have a newer ongoing trial called minoca BAT trial. They try to see the impact of beta blocker or ACE inhibitor or ARB to the patient, and the result at 4 years is pending. Next, after we know the diagnosis cause, like we do MRI, we do intravascular imaging, we define the patient whether have a plaque disruption, vasospasm, coronary microvascular dysfunction, or the emboli or coronary arterial dissection, or even a supply-demand mismatch. Then we can treat the patient right. I have to say that all the ACS, plaque erosion composed of around 25%, in the Western data, but in the Asian data, it may even higher, especially younger population and women. On the practice disruption, there's no established role of CORI PCI. Mainstay therapy now is a DAP, aspirin, and or P2Y12 inhibitors. However, 1-year revascular rate is around 5.7% in the patient with MINOCA that you have to keep in mind to follow these patients. Erosion study, they found that even we don't put the stent or do any balloon, this patient is safe up to 4 years with just a DAP medication. Epididymal coronary vasospasm is another common cause of MINOCA in Thailand. When we launch about marijuana for medical treat, we have a lot of cases with vasospasm too. And this is diagnosis criteria of vasospasm. Coronary microvascular dysfunction, this is a new entity that we explore more and more. There's a proposed criteria by the COVADIS group about the symptom of ischemia. Your absence of coronary artery, this is MINOCA. Have evidence of myocardial ischemia, and when they have positive cardiac sign, then you can diagnose MINOCA too. And then the last thing, have evidence of impaired coronary microvascular function. Also, when they look on the small group and a subgroup of coronary microvascular dysfunction, they also the group that have ACS, have positive cardiac sign, and this group that we so-called MINOCA. So that's the criteria and how we work up on the patient with vasospasm and CMD, both invasive tests and like a microvascular function test. And this is a scenario that we use, measure the pressure while do vasoreactive activity, and they will diagnose both vasospasm and CMD. We don't have time to talk today, but most of this group of patients, when we treat, we modify all the basic risk factors that we think is associated with coronary microvascular dysfunction. We have a medication like calcium channel blocker, long-acting nitrate for vasospasms. We have medication like aspirin, ACE, or statin that may work for coronary microvascular dysfunction. We also have a medication to relieve the pain like a lanolazine, beta blocker, or calcium channel blocker for this group of patients. The last is a coronary emboli and thrombosis. The thrombosis can happen in the patient with a hypercoagulable disorder. Coronary emboli can be from an intracoronary or come from other source. The high-risk group of patients, such as a prostatic heart valve, atrial fibrillation, low EF dilated cardiomyopathy, rheumatic heart, infective endocarditis, or atrial myxoma can cause coronary emboli. And coronary emboli sometimes can be bad, and you may need an aspiration to bring the thrombus or the clot out. The last thing that is a nightmare in the cath lab is a spontaneous coronary artery dissection. We found in the patient at a young age. The patient peripartum period is an increased risk. Also, history of fibromuscular dysplasia or migraine. The problem in this group of patients, nowadays, the patient can present with a STEMI. We inject, we found the blockage. Once you put a more balloon, more stent, there's more dissection along the way. So PCI will reserve only the proximal vessels or the patient with unstable. If the patient have mid to distal vessel lesion, we left it alone and repeat a coronary angiogram in 2 months. And we found that all vessels almost healed. Let's go back to our case. Our 60 years old who have a rising troponin a bit. And then the colleague said that after they do angiogram, they found only 40% mid-LED with the old stent restenosis. So I asked them to do intravascular imaging to find any cause. And at that time, we don't have the OCT. We did IVAS and show no any plaque erosion or anything at that point. However, we noticed the patient have all slow flow in all coronary artery. Then we also confirm with a physiologic study, we do IFR and FFR. The FFR is a 0.86, is more than 0.8, so no ischemia in these patients. So the patient quite fit to the diagnosis of MINOCA, and we thought it can be a slow flow related to a coronary microcirculation. So one thing, we want the patient to be sent for the cardiac MRI. The patient have claustrophobia. So we send the patient for cardiac straight PET scan instead. Once the patient is stable. And we found no perfusion defect, but the patient have a lower coronary flow reserve and coronary myocardial blood flow. So it fit the criteria of a coronary microvascular dysfunction. We give the patient a DAP because the patient is rising troponin. We modify risk factor and our medication. So the last thing from my talk today, I have to say MINOCA is not the same entity. They can cause by heterogeneous group of disease. Coronary angiogram or even a CT scan is an initial rule out to determine that the patient have significant blockage or not. More data on the intravascular imaging plus cardiac MRI is a good tools to work up on MINOCA. From the current evidence, I have to say MINOCA is a better biomedical treat, except some certain condition like an emergency condition, hemodynamic instability, some coronary arterial dissection in the proximal vessels, some certain coronary thrombosis or emboli that you need aspiration, that need intervention. This idea, I will not focus, that what presentation on MINOCA, what kind of diagnosis, and what therapeutic that they need. And these are all the intracoronary. You can see that actually MODS is a medication, it's not the intervention. And try to identify the cause. OCT and MRI combined together, you can work up cost around 80% of the patient. Thank you so much.
Thank you, Dr. Ratanapo. I think it's an extensive and a very elaborate topic, and you've really expressed it very well. Do we have any time? Do we have time for any questions? Does anyone have any questions?
Can I have a question for Dr. Ratanapo? Okay. We know that the intravascular imaging is very important for MINOCA, but how about the tips and tricks to use OCT or IVAS for these patients? Should we screen for the all three coronary vessels or just for one lesion we suspect?
Okay, thank you, Dr. Wang. That's a great question because we don't know where the troponin come from. So we have to go with the clinical too. Like if the patient have some echocardiogram change, then we can focus on some certain vessels. OCT is always the first choice in case of MINOCA because you can see the better like a plaque erosion. Sometimes we just see only a small thrombus lying on the endothelium that you can miss from the IVAS. So for me, I focus on just a certain vessels, mainly relate to the clinical, but there is some case that we're not so sure, like we inject and the patient have all three vessels, then you have to select because you cannot do a OCT all three vessels and then they're gonna use a lot of contrast. In that case, I may consider intravascular ultrasound. But if a patient all is a 30% blockage, 30 to 50%, sometimes we skip where the patient to be stabilized. We don't put the Y in at all. And then we select non-selective, non-invasive cardiac imaging later, like a MRI stress test, PET scan, nuclear scan.
Okay, thank you.
Thank you. I believe in the interest of time, we should move into our second speaker. It gives me great pleasure to introduce Professor Sujeeb Rajbhandari. He's associated with the National Academy of Medical Science. He's a senior consultant cardiologist, and he's the head of Department of Cardiology at Shahid Gangalal National Heart Center in Kathmandu, Nepal. And Dr. Rajbhandari is going to be talking on Takotsubo syndrome, emergency therapeutic strategy and outcome. Dr. Rajbhandari.
Thank you, Dr. Bijoy, for kind introduction. I was a little bit late because I was holed up in traffic. So good morning to all of the participants. So I'll be starting. I'll be sharing the photo document. How do I share the screen? Sorry. How do I share the? I want to share the. It's in my desktop. How do I share?
Well, you roll over your mouse to the button, you will
Documents.
see.
Okay, documents. Allow.
You see the.
So let me see. Okay, images, documents. It's not showing. Actually, it's in my screen.
Yeah, you can share. There is a button on the center, lower center part. Usually it's green. It's green color. Share screen.
Yeah, I know.
That one. Yeah, okay.
I know. Let me. Sorry for the delay. It's hung. I think it got hung. I downloaded it in just a minute. Excuse me for that. Sorry for the delay. Share a screen. Something. I want to share the screen, but it's not working.
Dr. Sujeeb, there's a button at the
Oh,
bottom.
there's a button. I put it in my. I'm using my this mobile, so it's still okay. Zoom. Okay. There's a button. I know there's a button which from where I can share the screen, but this one I know.
Usually it's a green button.
Oh, yeah. Green, but I didn't see the green. There's a share screen. Okay, green button. Okay.
Yeah, share screen and click the
Share
screen you like
there,
to share.
but
and start.
It might. Oh. Okay. Means. Somehow it's not coming in my. I've downloaded my thing, but it's not coming. I don't know why. It's the screen is in the there. I'm using my mobile phone because that.
Mobile phone, yeah. We usually it's still working, and you can try. But your PowerPoint is in your desktop or in your
PowerPoint I've downloaded, but it's not.
Dr. Bijoy?
Yes.
Yeah, okay, he's come back. I hope he's
Okay.
he seems he left.
Yeah.
Oh, something wrong.
He's having
He's
some
connecting.
technical
He's
issues.
maybe technical issue. Okay. So yes, please.
Is he logged in?
He's no, he just he logged out and he's coming. He's coming.
Okay.
I already now he's in and connect. I hope he's hi doctor.
Yeah.
We can see you now, and please continue. Yes, Dr. Sujeeb, you're okay. You can carry on your presentation. We can't hear you. Actually, we know
Yeah,
you
we
are
can't hear you.
talking, but we can't hear your voice. Oh yeah, you are. Yeah. Okay. It's okay. Great. We can see your mobile phone. Your mobile phone is working, and we are watching your mobile phone's content, and your presentation is in your mobile phone. Okay. Maybe you rotate 90 degrees. We will get a full screen of your presentation. Uh-oh, that's disappear. It's gone. It's disappear again.
Oh.
It's not maybe he logged out or accidentally he disconnected. So I will keep on watching he's coming or not. Perhaps you can carry on for the next speaker switch between these two speakers.
Yes, I think so. So I think
Wang?
let's move on to the third speaker, because I guess with these webinars and the internet is unstable, certain things we cannot control. So it gives me great pleasure to introduce our second speaker, Dr. Hyun Kuk Kim from Korea. He's a professor and at the Department of Cardiology, Heart Center in Chosun University Medical School, in Chosun University Hospital in Gwangju, Korea. And he's going to be talking to us about interventional strategy for multivessel acute myocardial infarction, IRA only or complete revascularization. Dr. Kim.
Thanks, Chairman. Hear me? Can you hear me?
Yes.
Can you my voice?
Yes,
okay.
We can hear you.
Thanks, Chairman. I'm Hyun Kuk Kim from Chosun University Hospital. It's my great honor to participate in the APSC webinar. My topic is about interventional strategy of multivessel AMI. There are three parts in my presentation. The first part is about clinical impact of multivessel AMI. In early 20s study, AMI patient with multiple plaque associated with recurrent ACS and revascularization compared with a single plaques. According to the representative 2010 study, about 50% of patients of AMI had multivessel disease, and patients with non-RA disease had a significantly higher mortality rate compared with without non-RA disease. We can assume the regions of these results by the prospect trial. The prospect trial included 697 HS patients who underwent angiogram and simultaneously 3-vessel IVUS during the median 3.4 years follow-up. Surprisingly, non-IR related events was developed similar with the IR-related events. The major risk factors of non-IR region events were the presence of syncape fiber aceroma and minimal lumen area and large amount of plaque burden. In my personal opinion, there are three regions of more events in multivessel AMI patients. First, AMI patients were more vulnerable. In these two studies, show that more events occurred in patients with ACS compared with the stable ischemic heart disease with a similar ischemic burden reflected by a fractional flow reserve values. We can see that clinical events could be developed more in AMI patients, even in non-ischemic vessel regions. Second, Korean platelet thrombosis research team, including me, recently reported that AMI patients had more thrombogenic features than non-AMI patients. We used the thromboelastography, which showed the global hemostasis for checking the thrombogeneity. Higher maximal amplitude reflects stronger platelet fibril close strength, and lowered lysis 30 reflect impaired fibrolysis. So the maximal amplitude and LI30, LI30 were independent predictors of AMI presentation and associated with the 4-year major adverse cardiac events in the risk registry. Third, in preclinical studies, myocardial infarction events itself associated with the disease progression in remote vascular area. This study used a double knockout mice, LDL receptor, ApoBac1, and then MI was induced by a coronary ligation, and they observed the remote vessel plaque progression in aorta, atherosclerotic plaque. In this experiment showed that in AMI group, plaque progression and inflammation reaction was prominent in the AMI group compared with the sham procedure. This study was performed by my post-science research team. In day 0, we made the AMI model by coronary occlusion by balloon catheter, and the other one performed the sham procedure. And then day 2 after the procedure, we performed the stent implantation both in the IRA and non-IRA simultaneously for observation of both the IRA and non-IRA region were associated more endothelial dysfunction reflected by the acetylcholine challenge test, and then more observed peristrate inflammation and fibrin in the AMI group, and more plaque progression in the AMI group compared with the sham procedure group. The second part of my presentation is about complete revascularization versus IRA only. Complete revascularization was not recommended due to the safety concern in 2013 ACCF AHA guideline for STEMI guideline. But this recommendation was based on the registry data or sub-analysis of RCT or our registry data set. We can see that retrospective studies tended to favor IR only, but prospective studies is a neutral effect. In 2017, is the ESC guideline for STEMI made 2A recommendation for complete revascularization based on the RCTs, including PRAMI and culprit, compare acute and dynamic pre-3 multi-trial. However, it said PRAMI trial, benefits of CR was mainly by reduced revascularization rather than the death MI, the hardware endpoint. And in non-STEMI, also made 2A recommendations for the CR, but level of evidence is C because of lack of RCTs, mainly driven by observational studies. In 2019, a game-changing trial for this issue was published in New England Journal of Medicine. They named the complete trial complete trial enrolled most largest number of STEMI patients compared with the previous RCTs and showed the CR, reduced the death or myocardial infarction. That is a hard endpoint than IR-only PCI. Based on the result of complete trial, 2021 ACC/AHA SKY guideline made a class 1 recommendation and level of evidence A for CR in STEMI patients. Therefore, CR or non-CR, especially STEMI, is not the issue anymore. The third part is the remaining issues when and how to achieve CR in AMI patients. The first is immediate CR. Multivessel AMI with cardiac shock in guideline recommended should not be performed in patient AMI complicated by cardiac shock. These recommendations are almost based on the one powerful RCT. The cautious point is that guideline prohibited immediate CR, not CR itself. In the corporate shock trial, immediate CR increased death and no benefits in the early phase over the CR, and no benefit in the longer term follow-up. Remaining issue in corporate shock trial, they made one baby in the corporate region only PCI group, 149 patients survived in corporate only PCI group, but 30 or 50% patient made a CR. So maybe they increased benefit of corporate only PCI group. And then they included 20% of CTO patients, but in our Korean data, decision CTO trial published in Circulation, they show that CTO PCI has little or no significant effect compared with just medical therapy. And then they reported that in 1 year data, the hospitalization for congestive heart failure is more developed in the corporate only PCI group. Now, recently, in the ACC late-breaking multivessel AMI without cardiac shock, a BioBasket trial was simultaneously published in Lancet. It's a prospective and open label and non-imperial trial. In patients presenting the ACS and multiple disease, immediate CR was not inferior to the staged CR. And they show that myocardial infarction or ischemic-driven revascularization was lower in the immediate CR, but it is the non-imperial trial, so you cannot conclude that it is superior than the stage CR. There are several upcoming studies about these issues, including option STEMI on the enrollment in Korea. Its enrollment rate is 90%. So we can see the result of these studies to seek the answer for these issues. Second is angiography only PCI versus physiologic guided PCI for the CR. There are many cardiologists or interventionists did not believe the FFR value in the non-IRA region in AMI patients. So we make a visual experiment with Jung Lee in Samsung Medical Center and Lim in Korea Research Center. So we made a cosine experiment using a microsphere and the Doppler wire and something. So we report that non-IRA FFR reliable except unstable bias because in the microsphere insertion, IR region arising the IMR, so microvascular injury, and then FFR value elevated according to the microvascular injury. But in non-microsphere, non-IR region, there is no significant change in the IMR and FFR values. And it's a pathology, no microvascular injury region, CFR and IMR was intact, and the region of microvascular injury is a necrosis in this myocardium and microvasculature. It showed the microvascular dysfunction according to the CFR and IMR submodulation method. And then we also saw the balloon occlusion in the circumflex and then checked the Doppler wire as peak velocity using a Doppler wire. It showed no change in the FFR value in non-IR region. The first RCT about angiography versus FFR-guided CR is the Flower AMI trial. It is published in the New England Journal of Medicine. They show that there are no differences between the FFR revascularization and angiography-guided revascularization. But this study there is some limitation in that study because the PCR rate was only 55% in the FFR group. It's a very lower the PCI, but 2 times higher periprosal MI in FFR-guided group, and only 70% non-I PCR in FFR group, resulting in TIMI-3 flow. It means that 30% of non-I PCR in FFR group was below the TIMI-2 flow. And then angio-guided group showed a 3.5 times higher incidence of cardiac death, mainly sudden cardiac death, than FFR-guided group, and 16% of non-I FFR data was missing. No core laboratory analysis for FFR in the Bravo AMI. So it is our country data. The second RCT for these issues is a frame AMI trial. They can show the angio-guided CR was inferior to FFR-guided, but according to the COVID-19 situation, we cannot early termination, so it has some limited power. So we made a frame AMI QFR sub-study for explaining the results. They show that we use the angio-guided FFR value is a QFR. It can measure the angiography itself, and they show that high QFR and PCI group in the angiography guided PCI show the worse outcome, and similar with the no QFR superior result of FFR guided PCI. Dr. Samir Mehta wrote the editorial for our frame AMI trial. He said the difference between the two trial is first one is a reliable FFR measurement and 60% immediate PCI and 48% included non-STEMI, and we have a longer duration. And they say that they will make a complete 2 trial, a STEMI or non-STEMI multiple coronary disease, and number is 5,000 patients, and then maybe we can see the answer for these issues. So, ladies and gentlemen, it's my summary. The first one is multivessel AMI is associated with the worst outcomes compared with non-AMI and single vessel. And complete revascularization is class 1 and level of evidence A in STEMI, and maybe beneficial in non-STEMI patients. And the remaining issues when to and how to achieve complete revascularization is awaiting upcoming ISTs about these issues. Thank you for listening.
Thank you, Professor Kim. Do we have any questions?
May I have a question for Dr. Kim? We know from your slide, we see that the CTO lesion is about 20% in AMI patient with multivessel disease. And we know that sometimes the IRA supply the collateral to the CTO lesion, but some are not. Is there any difference when we treat these two different kind of situation?
In cardiogenic shock patients?
No, it's stable patient.
Stable patient. In our country, we have a MI registry named the Camil Data. They reported that there are no significant differences between the two groups.
Okay.
I think that maybe prognosis is similar, but maybe. Thank you for your very good question.
Thank you. Thank you.
Thank you, Dr. Kim. I'd like to request my co-chair, Professor Wang, to kindly take over.
Okay, maybe is Dr. Sujeeb ready? We cannot hear you, Dr. Sujeeb.
Okay, we can see
Okay,
your
okay,
presentation.
okay, we can see your slide. I think that maybe Dr. Suji can proceed his presentation. Please.
Can you hear me? Can you hear me? Can you hear me? Can you hear me?
Yeah, we can
Uh,
hear you. Intermittent, not so clear, but
not
we
very
can hear you.
clear.
So I'll be talking about cardiomyopathy. Emergency. The Japanese, I think, Japanese spot capped off ocean. To cap you off. So in the next slide, I'm going to normal heart on the left side, broken heart on the right side. So in the broken heart, like the spot. Part of the heart. How the human, what are the other names for that? Term as and the definition syndrome characterized by transient regional common regional usually less, mostly less, often right ventricular. The important point is that absence of significant coronary artery. It was first described in Japan by the preponderance of some of the studies will become 100%. The mean is about 7 years. But surprisingly, it was also seen in children and 90% of the cases are post-medical. And if you look at the troponin positive cases, 1% troponin positive cases. And in one case, incidence was 1.7. It's commonly seen in exact pathogenesis is not known. I will consider that not emotional, the disease of causes which cause microvascular spasm or direct proximity to and but there are rare instances. Now, other possible mechanisms are impaired myocardial underlying coronary. So, yes, etiology is the physical of mental. Physical triggers are more of emotional. 28.5%. What are the triggers? Death of loved one, bad financial news, bad newly diagnosed use or withdrawal. Also reported after near drowning. Type, common type is because it is known that high concentration of in the atypically weak ventricular after death, weak ventricular affect mid ventricular level of almost the LVOT is there's a strong contraction and ballooning out. And the other side, then left side, on the right side, you can see the apex is here during students with mineral cavity. So how do we diagnose? We can diagnose by transient regional wall motion. The portion of the regional wall is not covered by a single. Actually, the wall motion is beyond the area supplied by a single. And there should be absence of obstructive permeability or or even and the elevation is properly modest. And of course, we have to include myocardial infarction. There are a lot of criteria. Most that one set of what the person comes with. But surprisingly, in the people who have there are no incidents of what does common however mainly in the mid and may be prolonged. May be and so a person comes with ST elevation. You won't know that. If you think about your life, and if the criteria for no need to hold the factor line. And of course, if there's a primary then and if person comes with one stability, just I describe it. Cardiac biomarker in 90% of lesser in magnitude. Kinase can be normal. Then nitric. What are the other? It can be echocardiogram, angiogram with cardiac MRI is indicated to examine the top of concomitant. Take the MRI and feature of how it intense myocardial however myocardial one of the 26% has right ventricle wall and they have also had low difference. So coming to the differential diagnosis and then came amphetamine related prenatal myocardial and recovery of and this the mechanism is and And 5% what are the benefits? The results aim of benefit. I will heart failure. In case of avoid that. But homeomonism or medication. However, usually the regular 95%.
Thank you, Dr. Suji. I'm sorry that we cannot hear your sound very clearly, but your slides are very clear. And any questions from the audience or the panelists? May I have a, maybe I have a short question. I saw in your slide that IABP is a choice for Takotsubo disease with LVOT obstruction, but I think IABP will decrease the afterload and may exacerbate the degree of LVOT obstruction. How about the use of this kind of device in such situation? Sorry, we still.
Dr. Suji, please stop sharing your presentation. Maybe you will make the voice more clearly.
Yeah, the sound is not very clear. Maybe.
Please stop sharing so that, the bandwidth can go through your audio.
We still cannot hear your voice. Okay, thank you for your lecture, and maybe we have to move to the next session. And it's my honor to introduce the next speaker, Dr. Bassam Ababa from the United Arab Emirates. Dr. Ababa is the professor and the consultant of cardiology and interventional cardiology at Al-Qasimi Hospital. And his topic today is acute myocardial infarction with cardiogenic shock, role of mechanical circulatory support. Dr. Ababa, please.
Hello, can you hear me?
Yes, we can hear you.
Yes, thank you. First, hello everyone. I would like to thank the organizing committee for sharing me in this session. I am sharing now from Germany. Still, it is night time. This is my talk. There is nothing for disclosure. This is my agenda in my talk. I will start with background and introduction. As you know, that cardiogenic shock complicates acute ST.
Dr. Ababa, can you share
Yes.
your slide? Share your slide.
I share. It is not sharing.
Yeah, we cannot see your slide.
You can see my slide.
Yes, we cannot see.
You can see or not?
Oh, we cannot see your slide.
You cannot see.
Yeah.
Now. You can see my slide or not?
Not.
Even like this? You cannot see, huh?
Yeah, cannot. We cannot. Okay, it's okay.
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 Can make it full screen. It's okay without full screen?
Maybe you can use the full screen.
Please start display actually your presentation. Start your presentation on the
yes,
left,
I will start,
right
but now
corner.
it is not full screen. How can I
Yeah.
make it full screen? By press.
Are you using the dual screen? Do you have a dual screen? Two screen in front of you.
I have icon for, but what happened that something. Okay.
Yeah, you can. There is a left, lower right hand side. Yeah, that's the play.
Okay.
Display.
Okay.
Okay, great.
This
Okay,
is my agenda. This is first. This is my talk. This is my agenda. I will start with background cardiogenic shock complicate ST elevation MI in 5 to 10%. Despite immediate revascularization and pharmacological support, mortality is still very high. In ST elevation myocardial infarction, cardiogenic shock is typically due to ventricle pump failure, but there is some cases we have to recognize that mechanical complication may be implicated. Short-term mechanical circulatory support devices acutely improve hemodynamic condition, but they are not free of potential complication, behind the cost. Evidence to guide this treatment is low, really, and the use of is based on expert consensus, conflicting retrospective studies, and small underpowered randomized trial. Etiology of cardiogenic shock, it is multi, ranging from acute MI and mechanical complication to cardiac tamponade but of course my talk it is about ST elevation MI and cardiogenic shock. And the spectrum of cardiogenic shock, it is really wide, ranging from pre-shock status to mild shock and profound shock and refractory shock. And the management is different with each step of this spectrum, and the prognosis is completely different between step and step. So early recognition, early management is must and is essential, and it makes sense in management of this complication. You know that the prognosis regarding cardiogenic shock is different if it is related to acute MI or related to the heart failure. And the prognosis in case of acute MI is worse than that associated with acute heart failure. So this is less tolerance of hemometabolic perfusion in case of acute myocardial infarction. I will start with this registry, new registry for 18 years coming from USA, as they recognized 4.3 million ST elevation admission and cardiogenic shock percentage, it was 8.5. And during this 18 years, they noticed the increase that the incidence of cardiogenic shock increased significantly from 5.8 in 2000 to 13.0 in 2017. And also multi-organ failure increased in significant way from 2012 till 2017. And also the angio and BCI increase in significant way in this period. And the use of intra-aortic balloon pump during this time, which is too long time, it decreased, while another mechanical assistant device use in cardiogenic shock increased from 0% to 12.9%, and the hospital mortality decreased in significant way from 49.6% to 32.7%. Decreased, so the mortality decreased, risk decreased. This is a family of mechanical circulatory support devices which for temporary use, short mechanical circulatory support, starting from intra-aortic balloon pump, Imbella family, Tandem family, ECMO family, and Centrimag. And some of them are recruited to have evidence benefit for LV, left ventricular failure, and other for right ventricular failure. And some of them, we can get from them benefit for both, like VA ECMO. What about intra-aortic balloon pump? You know, this is the first used in cardiogenic shock complicating ST elevation MI. And according to this analysis, this study, which is intra-aortic balloon pump shock 2 trials, which is published 2013, 30 years, at 30 years, there is no difference in mortality between the two arms if we use intra-aortic balloon pump or not. And the same result extend to more than 1 year. Also, there is no difference regarding mortality between the two groups if we use intra-aortic balloon pump or not. So according to that, the guidelines shift the recommendation for using intra-aortic balloon pump in cardiogenic shock from 1C to 3B. So it is now not recommended to be used as a routine, but sometimes we have to use it. But it is recommended not to use it as a routine. What other family of this group of mechanical circulatory support? You know that there is another member in this family, including VA ECMO and tandem heart, Embella CB, and Embella RP. And each of them have different way and they recruit different access. For example, for VA ECMO, they recruit cable vein and aorta as destination. And for Embella RB, from right atrium to pulmonary artery for destination. And for tandem heart, from left atrium to aorta. And for left Embella, it is from left ventricle to proximal Embella. And regarding the intra-aortic balloon pump, as you know, from proximal aorta to aorta. So, which devices and when to go for it? Really, it is rely in which ventricle is affected during cardiogenic shock complicating ST elevation MI. Most of the cases, it is either left ventricle or biventricle in 93% of the cases, but RV, isolated RV affected only in 7% of cases like RVMI, especially if complicated with complete heart block. This is the Embella family. The most used is Embella CB because it may provide 4 liters supply in each minute, and it can be done through percutaneous puncture, while Embella 5, it need cut down at the femoral side, and in the Embella 2.5, it is the effective of it is minimal. And also there is Embella RB, which bumping the blood, transfers the blood from right atrium to the ascending aorta. And also regarding percutaneous VA ECMO, which extracted blood from right atrium to external oxygenator, then transfer the blood to the aorta, and there is some complication regarding this, like limb ischemia and increased left ventricle afterload, so may precipitate pulmonary edema. Right. So there is question should be raised: is there a mortality benefit by mechanical circulatory support, and what about evidence from matched comparisons? First, we have to know we have to balance between the risk or complication from inserting this kind of devices and the benefit, forgetting the high cost of these devices. And we remind ourselves of complications like hemorrhage, infection, hemolysis, limb ischemia, embolic, and the thrombotic event related to these devices. I will start with this matching study, which matched Embella, supporting patient coming with cardiogenic shock complicating acute ST elevation MI, and the result coming from shock 2 trials regarding the efficacy of intra-aortic balloon pump, and this is published in 2019. The result, it was shocking. No benefit regarding mortality between Embella versus intra-aortic balloon pump in this matched comparison. And so you can recognize no difference regarding mortality, but the peripheral complication and bleeding and also sepsis all higher in significant statistic evidence in Embella arm. The same if you compare in this matching study between Embella and intra-aortic balloon pump, which is more recent than the previous one, which is published in 2020 and recruit a higher number of patients comparing Embella and intra-aortic balloon pump. The death, it was higher in significant way in the Embella arm, and also the major bleeding higher in significant way in the Embella arm. So here you can recognize also in third matching study how the intra-aortic survival with intra-aortic balloon pump is better than Embella. So what about the Japanese experience and registry regarding using this mechanical circulatory support, which is published recently, and they found that if we use Embella alone or Embella with ECMO, the benefit is better regarding survival if we use Embella alone. So adding ECMO, VA ECMO, it decreases the survival benefit, or it make it is the survival benefit. It is much the survival. It was only 45.7%. But if we use Embella alone, the survival, it is double. It is 80.9%. Another another from Japanese also registry, which is recently published, that they compare if we use VA ECMO plus intra-aortic balloon pump, or we use only VA ECMO plus, or VA ECMO plus intra-aortic balloon pump, or if we use only VA ECMO. So the survival rate, if we use intra-aortic balloon pump with ECMO, it is better, because as I mentioned before, that ECMO may increase the afterload of the left ventricle, so may precipitate pulmonary edema. So this study sounding regarding the benefit of adding VA ECMO plus intra-aortic balloon pump to increase survival in patient presenting with ST elevation MI and cardiogenic shock. But the registry coming from USA regarding this combination of VA ECMO and intra-aortic balloon pump have fair result, that there is no difference between the two arms if we use VA ECMO alone or if we use VA ECMO with intra-aortic balloon pump. But the bleeding, the hemolysis with the arm of using both is high. Sorry. Sorry. Again, this study from USA, it is recruiting Imbella versus intra-aortic balloon pump in patient using VA ECMO. And the result regarding survival, it is the same, but the hemolysis, it is higher if we use ECMO with Imbella. So it is different from the Japanese study. How to triage to mechanical circulatory support? First, we have to use BAC guided to guide us. First, we have to ask our question, self the question: what level and type of shock our patient, and what devices need, and what is post-device management, and should be all done in a quick heart team meeting for this kind of cases, which should be done on time without losing any time, because time is muscle and time is survival in patient with ST elevation MI complicating with cardiogenic shock. This is a potential strategy for general strategy to deal with patient with shock from acute ST elevation MI. First, we have to use Imbella CB, which is the best, and it is easy, and it is time consuming. There is no delay. It takes about 12 minutes to be inserted. Then we reassess the patient regarding hemodynamic. We have to do first BCI before or after Imbella insertion. Then we reassess hemodynamic, urine output, lactate. So maybe escalate the devices to add intra-aortic balloon pump or add ECMO to this kind of patient. You know that in hospital time, we have not to do any delay to insert. If there is an indication to insert any mechanical support device, we have to do it in short time, because any delay, it will be reflected in the mortality in significant way, as it is it clear in this meta-analysis of a huge number. Timing of short-term mechanical, early or late, we have to know that door to support in acute myocardial infarction complicated. This is meta-analysis published recently, which in patient with ST elevation MI, and recruited a huge number of patients from many retrospective study and one randomized study. And the conclusion that short-term mortality was reduced in patient receiving pre-BCI Imbella support from 37.2% versus 53.6%. So significant reduction of mortality when we recruit devices earlier pre-BCI, and this extend to mid-term mortality benefit also the same, not only in short time, but also in mid-term benefit. So conclusion, Imbella prior to BCI in acute MI cardiogenic shock may have a positive impact on short and mid-term mortality compared with post-PCI placement, but as we know, no safety concern about device-related bleeding and limb ischemia. I will mention two special kind of cardiogenic shock presenting with acute MI, which is RV infarction, and which is maybe complicated with RVMI, especially if the patient having complete heart block. In Bella RV, may we get benefit, significant benefit, because as you know, RVMI and cardiogenic shock, RV usually recover in short time if we did BCI and reperfusion therapy for the infarct-related artery. The recover time period regarding RV, it is much faster than LV. Finally, I will mention to the mechanical complication which may due to the ventricular septal rupture or papillary muscle. In this kind of patient, usually the ventricular septal rupture happen within 24 hours, but may up to 2 weeks, and patient may get benefit. This is the only patient, special patient may get a great benefit from intra-aortic balloon pump before doing the surgery, because it is better to postpone the surgery for 2 to 3 weeks after fixing the septal defect. The same regarding papillary muscle rupture, which may happen during 2 to 7 days. But in this case, also we can get great benefit from intra-aortic balloon pump. But in this case, we have to do surgery as early as possible, not like VSD rupture. So, in conclusion, the use of temporary mechanical circulatory device in cardiogenic shock has increased dramatically despite a lack of robust randomized controlled trial or evidence suggesting a significant improvement in mortality. What about guideline about using these devices? 2016, the recommendation, it was that short-term mechanical circulatory support may be considered in refractory cardiogenic shock, depending on patient age, comorbidities, and the neurologic function. But in 2021, the recommendation upgraded to 2A, but now maybe by the end of 2023, because of the lack of the evidence, maybe I am afraid to be considered as 3A as a routine use, because we have till now not having enough evidence supporting use this circulatory devices. So in conclusion, mechanical circulatory support devices selection should be individualized to the patient according to the shock severity. It is used only in type C, D, E, and according to shock phenotype, it is due to the acute MI or decompensated heart failure. If it is the type of device, if it is unilateral ventricle or biventricular, and should be guided by invasive hemodynamic and device availability, and even also operator experience. Multidisciplinary shock team approach is must. Importance of shortened onset of shock to support time, if indicated in the similar time fashion to door to balloon in ST elevation MI also is must. Thank you for your attention, and sorry if I exceed the time.
Thank you, Dr. Ababa. Any questions from the panelists? May I have a short question? We
Yes.
saw from your lecture that the combination of the supporting device is very interesting, but both studies include ECMO as one of the combination. How about the use of two unloading devices, such as IABP plus Impella? Is there any evidence of using two unloading devices?
You mean what is Impella plus what?
Plus IABP.
Intra-aortic balloon pump.
Yeah, yeah.
Yes, it is indicated sometimes, especially if the patient develop like heart failure or pulmonary edema, because as I mentioned before, all other devices like Impella or VA ECMO, it increase the afterload, so may precipitate pulmonary edema. And these devices should be, when used, should be controlled by hemodynamic and close monitoring. So if patient develop increase in wedge pressure and any signs of heart failure, this should be, and there is some study supporting that compared with ECMO alone or ECMO plus intra-aortic balloon pump.
Okay, thank you.
Thank you.
Thank you. And because time is up and I have to make a short closing, and I have to show my special thanks to the 4 speakers and their excellent presentations. We learned a lot about how to choose adequate therapy in each disease entity. However, we still have some puzzles in each disease entity. I think the unsolved questions should be answered by the future studies and the randomized clinical trials. Finally, I have to say thank you to Dr. Rajbanshi as the co-chair and Professor Junyi Lin as the program director. And thank you all again, and hope to see you soon. Bye-bye.
Thank you.
Thank you. Bye.
Thank you so much.
Thank you.